Hi everyone, I'm John from HTN and welcome to this webinar today, where we are set to explore how digital innovation is improving skin cancer pathways at the Royal Cornwall Hospital's NHS Trust. And I'm pleased to welcome Dr. Sandy Anderson, the consultant dermatologist at Royal Cornwall Hospital's NHS Trust, and Gabby Cohen, the Director of Delivery at Isla Health, who are joining us today to take us through this project. So over the course of this session, we will look in depth at how technology is transforming the skin cancer care at the Royal Cornwall Hospital. And recently, this project was announced as Case Study of the Year in the HTN Awards, which is a programme run and supported by over 150 NHS professionals who judge the awards and ultimately pick the winners. And this project won in Case Study of the Year. So I think it's a fantastic opportunity to drill into this project in detail and share it with you in the audience. So in this session today, I have some questions that I'll ask to Sandy and Gabby. Sandy will take you through the project and we'll hear from Gabby and the team behind the innovation in terms of how it was implemented, the challenges and how they overcome those, and as well how that impacted the clinical productivity and patient outcomes. So we've got lots to share. But also, this is an opportunity for you in the audience as well to ask any questions. So if you have anything that you would like to ask, type them into the chat and we'll have a look at those as we go. And there's also time for a planned Q&A towards the end of the session as well. So in terms of housekeeping, there's only one thing to mention, that the session will be recorded and there will be a write-up done by the HDN team, so you can read or watch the session back at a later date and share it with your colleagues. So I think let's get started. Sandy, could I come to you, please, in terms of an introduction, and could you provide an overview of this case study from your point of view?
Yeah, thanks, John. Thanks for the opportunity to speak. I'm a locum consultant at Truro. I've been in the department about 15 years. I have a slightly checkered background of general surgery and then general practice and then dermatology. So I'm becoming a consultant through the portfolio pathway. And my main experience and passion, I guess, has been skin cancer diagnosis and complex surgery. So if we could start the slides, please, Jenny. Yeah, that's me. So this project began over a year ago on the background of the kind of problems which everyone is facing in dermatology, which was escalating skin cancer referral rates and shrinking and just inadequate workforce. So we all know that there's kind of 25% of consultant dermatology posts unfilled in England. And it's particularly difficult in Cornwall because it's so geographically remote to fill substantive posts. And in the last 7 or 8 years, in fact, in the last 10 years, our skin cancer 2-week wait referrals have gone from around about 3,500 a year to 10,000 a year. So 200 patients a week. And we've always, up until this initiative, done a traditional model where we didn't particularly screen 2-week wait or suspected cancer referrals. We just saw them all face to face with a dermatology specialist. So next slide, please. The other challenge which we have in Cornwall, although some may say it's a blessing, is there's no plastic surgeons at all. So our nearest plastic surgeon department is in a neighbouring county. They'll do some in-reach clinics for specific problems, but no surgery. We've currently got less than 2 whole-time equivalent substantive consultants for a population of about 500,000. And that's our very handsome healthcare assistant, Dan. Next slide, please. So the model that we wanted to investigate was a low-cost, high-volume tele-triage of suspected skin cancer. So from the start, we had to make it be more efficient for doctor time. It had to be to work with what we already had because we didn't have external grants or lots of funding, and it had to be acceptable to patients. So the model is that as many as we can of our 2-week wait patients anyway, we're triaged straight to this thing called a click. So click's a term I've stolen from Colin Fleming, a dermatology professor in Dundee, who's doing a very similar model, community lesion imaging clinic. So these were set up in what's now 5 locations across Cornwall, which is good for our patients because they were all coming centrally beforehand. We've set them up in whatever healthcare facilities are available. So most of these are community hospitals owned by the NHS, which have small outpatient departments or clinic rooms that we can borrow. We send 2 lowly paid Band 4 healthcare assistants to run their own clinic with an iPad running the Isla cloud-based platform and a nice Dermlite DL4 dermatoscope, which is the normal kind of dermatoscope that we use in clinic, which has there's a little clamp-on magnet connector for the iPad. And the other thing we send them with is a cheapo Amazon macro lens, which improves the quality of macro pictures on the iPad because it's not as good as an iPhone. We debated using iPhones, but the iPad we can use for questionnaire entry as well as image capture. So it's one device does everything. Next slide, please. So we wanted to keep our inclusion as broad as possible and capture as many of our 2-week waits as we could. So just said all adults, maximum 3 lesions mentioned by the GP, because we felt more than this was just going to get increase the risk of imaging the wrong thing, and not genital because it was just a step too far for our poor healthcare assistants. Next slide, please. So this is our initial results from early 24, so the first 1,400 patients. So they're all seen in our clicks. We're up to about 180 patients a week from our 200 a week average. And they're all tele-triaged by myself, or there's about 3 of us doing it now. So 24.5% we discharged back to the GP with advice. So they were obviously benign, obvious Bones disease, obvious actinic keratosis, benign moles, seborrheic keratosis, those kind of conditions. We added 40% almost to a day case list for biopsy or excision. Often actually the barn door skin cancers we felt we could just excise and then they could see our specialist nurses later for diagnosis and follow-up. And we triaged a third, so 34% as needing face-to-face review, which was not the patients you might expect. It was more patients with indeterminate lesions, which were somewhere on that kind of boundary between benign and malignant. There's a tiny number. We arranged follow-up. For instance, if they'd had Effudix recently and they had inflammation side effects, we would see them in a few weeks later. And a small amount we referred to another surgical specialty, which would usually be oculoplastics for eyelid lesions. Next slide, please. So yeah, so this is as it says. So from seeing 100% of patients face-to-face, we've dropped to avoid 65% of those initial face-to-face reviews, which has obviously freed our team up to do the rest of dermatology, because that's the big risk, isn't it? I'm sure for all of our units, is that the skin cancer work just takes over. The numbers are so big, and the urgency is there, and the inflammatory dermatology just gets squashed to the side. Next slide, please. So one potential criticism is that where we're missing skin cancers, and where we, in particular, where we doing far more biopsies. Because if you're triaging people straight to biopsy, it might be that we're doing a lot more histology, but we're not, basically. This is a paper that we just put out the year before based on our normal standard 2-week wait, where 52% of patients had, 48.6 in that study had a histological procedure. And from the patients going through our click system, it's 52, so very similar. It's always been about 50% over years and years and years of re-auditing in our series. And the proportion of patients diagnosed with malignancy is always about 30%. And you can see there that it's the same in both 28.9% in our study of the clicks and 29.3% in the previous study. So that was reassuring to us. Next slide, please. And then the other question is, have you missed cancer? So one, have you missed the index lesion by misdiagnosing it because you've only got teletriage? And two, have we missed incidental cancers because we're obviously not offering a skin check, which to me is the biggest criticism of telederm for lesions. And in our 1,400 patients, we say we missed 3 cancers. We really missed one. We missed one small pink amelanotic melanoma and misdiagnosed it as benign. There were 2 superficial BCC, which we diagnosed as Bowen's, but since the treatment's exactly the same, then that's not really affected patient management at all. And 6 patients of the 1,400 were diagnosed with a new skin cancer in the 6 months after their a different site in the 6 months after their appointment, which I'm sure is pretty standard to our face-to-face cohort. If we could have the next slide, please. Yes, and this is a paper we just put out recently saying, looking at the miss rate for skin cancer face-to-face. And this is something which people don't like to discuss or admit to, but because we're moving towards AI as a tool, I've felt for a long time we need to have some kind of realistic standard to of misdiagnosis rate of the humans that we can compare AI to. And we found that we'd missed 2% of our malignant melanomas had been misdiagnosed as benign by one of us, which is similar to other studies. So this is just to say that missing the one melanoma was probably pretty consistent with the rates from our face-to-face clinics. Next slide, please. So to conclude, we reckon it's a safe and effective way to operate in keeping with a number of trusts across the UK. We reduced our face-to-face appointments by 2/3 of patients who we went through this system. There was a tiny missed cancer rate similar to our face-to-face work. And as a byproduct, we're building up a big collection of really high quality dermoscopic and clinical images and metadata, which will be ready to contribute to kind of nationwide databases to test and train AI, which is really where we're moving with skin cancer diagnosis in the UK. Next slide, I think that might be it. Yeah.
Excellent. Thank you for that, Sandy. That was fantastic, and keen to go into that in more detail as well over the next hour. And if anybody in the audience has any questions, type them into the chat. But before we do that, I'd like to come to Gabby. Welcome to the webinar. Gabby, could you provide an introduction, please? And also keen to hear the case study from your perspective, if you could provide an overview, please.
Absolutely, John. Thank you. So my name's Gabby Cohen. I'm the Director of Delivery at Isla. And the delivery team is responsible for implementation and evaluation. So really focused on kind of all of the things that sit behind some of these brilliant results that you've seen presented by Sandy. And one of the things that you can be quite sure of when you look at these kinds of outcomes and the rigor of what Sandy and the team have produced over here is that you have really strong clinical leadership and you also have a really rigorous implementation that sits behind this. And that's really what our team focuses on, is making sure that at every step of the process, we as the supplier are focused on how we can make it easier for the various teams at Royal Cornwall that worked on this to get it over the line. And that is working kind of collaboratively with a number of different teams, all the way from contracting, information governance, clinical safety, through to mapping the interoperability required to do this project well. In this context, it's a bi-directional HL7 feed, which I think we'll talk about a little bit later, through into clinical mobilization and getting everyone trained and really comfortable with the platform, and then into evaluation and business as usual eventually. And what our team really focuses on is understanding the key thing we are trying to impact or change and the mechanisms that sit behind that, so that we can look at the suite of functionality that Isla offers and make sure that we're creating a best of breed pathway that can be implemented at our different clinical sites. So that's really kind of how the team sits around this and how we work with the various teams at Royal Cornwall to make sure that this happens hopefully as efficiently as possible and we drive through the outcomes that we hope to see.
Fantastic. Thank you, Gabby. Right, so we've got some questions in the chat, so I'll just cover a couple of those. And the first one is for you, Sandy. Did you have to put on extra surgical lists, is the question.
No, because none of this is new work. So there's there's not an increase in the number of biopsies or excisions. Having said that, so basically, I suppose I should have said at the start that the primary bottleneck for our department, and I think for a lot of people, is availability of specialist dermatologists, and everything else is much easier to increase and flex than recruiting dermatologists because there just aren't any. So it's quite easy to train nurses to do biopsies and excisions. You know, band 5, 6 nurse could be trained to do biopsies perfectly well in 6 months. So we've moved towards that in the last few years of having nurse biopsy lists. The Isla software allows us to mark the images. So if I'm when I'm triaging you, I would do a day case booking at the same time for a biopsy. And I'd mark it electronically with a little circle and some text saying 4 mil punch biopsy, and complete our standard booking form on the normal hospital system. So when they come back to these day case lists, the nurse or doctor, if it's an excision or something more complex, has got a marked image and our day case booking form. The standard surgical questions, there's only 3, isn't there really? Anticoagulants, pacemaker, and allergies. They're in the click questionnaire. So that's all present for people to. So no extra lists.
Thank you.
Yeah, a shift from doctors doing see and treat on the day, I guess, to nurse-led day case.
Excellent. Can we chat about clinical efficiency and just to cover some of the impacts and the drivers for these changes? I'll ask the same question to you both. Sandy, could I start with you for this one? So how have these changes impacted the overall efficiency in practice? And do you think that digital pathways have been the key driver for these changes?
So yes, I think from the beginning, my priority was to make this as quick for the doctor as possible, and that's a selfish goal perhaps, but that's because of where the bottleneck is. So if we made this time consuming and laborious, then it just would it wouldn't be any more efficient than seeing them face to face. And I know people who've engaged in dermatology type services, which are seeing similar numbers to face to face. So we had to see the doctor to be able to handle big numbers quickly, and Isla's been really good for that. And part of the reason is that we've worked with the team to kind of modify the product and adapt it for our needs and make it as kind of tick out everything we don't need and put in what we do need. So it takes me less than an hour to triage and list and do all the actions, including letters and things, for a 4-hour clinic. So we see the HCAs see 15 patients in clinic, which is a fair-sized lesion clinic in the community, and it takes me about 45-50 minutes to action that on Isla. And we've got admin support as well. So I don't mind using healthcare assistants and nurses and admin staff to support the process so that the dermatologist can rack through big numbers. And that's the way we've done it. So our admin staff make the letters based on standard templates and copy and paste comments from the my Isla output form.
Great, thank you. Gabby, from your perspective, how have these changes impacted efficiency, and what's been the impact, if you could take that from a technology perspective and your perspective in this project?
Absolutely. So I think kind of the key thing to acknowledge is the very clear need that's very specific to the Royal Cornwall geography of really meeting patients where they are within the community and not making them travel unnecessarily. And inherently, there's a tech need for that, which is to be able to access this data really effectively and securely from multiple different locations. So I think fundamentally having that need really clear means that there was just a very practical element to why this needed to be a digital driven implementation. As Sandy says, it's kind of the savings of time to review, how many face-to-face clinics got shifted to remote, which was about half, roughly half, that drive and justified the kind of continued use of this implementation. What's really interesting from our perspective is taking a step back and thinking about what has to be true for digital to meaningfully drive transformation or the kinds of impacts that we're seeing in this case study. And fundamentally, I don't think any of these will come as a surprise to anyone, but it's clarity on what we're trying to solve for. This is a 2-week wait pathway. There's some very clear KPIs that need to be shifted as a signal of success. It's also making sure that these pathways really make the most of interoperability and that systems speak to each other in the most effective way. And I think Sandy will be able to talk to what that actually looks like from a clinical perspective, but we spend a lot of time, and I'm sure I'll be preaching to the choir, making sure that the systems don't add any kind of clinical burden or overhead when we're trying to solve this problem of kind of clinical efficiency. And then the last one is making sure that everyone within the pathway is really clear on what their role is. So as Sandy said, we're leveraging lots of different members in this pathway. There's nurses, there's HCAs, there's the consultants. So training is really fundamental for making sure that everyone's clear on what their pathway looks like, what their role is within the pathway. And the way that we did this in this implementation was training Sandy and some of the consultants, and then providing some kind of videos and user guides. And then Sandy used that to create a module for the HCAs. So everyone's kind of singing from the same hymn sheet, and everyone's really clear on what their role is within this pathway.
Fantastic. Thank you, Gabby. And just to pick up on a point that you've made in terms of interoperability and working between systems, Sandy, what's your perspective? How does that look in practice?
So it's good for us. We had weekly meetings when we were setting this up, which then continued certainly for the first few months with Isla and our IT guys and our information security and our kind of local managers to make it as efficient as possible. So after it started, we managed to, when we started, we were uploading referral letters by hand into Isla, because I felt very much the triaging doctor should just be within Isla. You shouldn't have to have 4 systems open and be dotting between them like we usually are. So we've tried to keep as much as we possibly can in Isla, apart from booking the procedures, which is on our traditional system. But then we've managed to automate that, so they get pulled, the referral letters now get pulled straight from ERS into the patient's Isla record when a patient's added to a clinic. So these triage clinics are all on our standard, it's not quite an EPR, but it will be. And that's the trigger. So when the patient's added to the clinic list, then their Isla records created and their referral letters pulled through. And then, so I'm in Isla, I have the referral letter there, I have the questionnaire data there, I have the images there. I fill in a quick review form with my opinion and outcomes and some coded kind of image quality type data. And then we just select everything and output it as a PDF back to with a kind of one click back to our electronic patient record. And so actually when our admin staff are out coming the clinics and doing letters, they don't necessarily need to be in Isla. They can, if they choose, they can stay in the existing EPR and just see that, review that PDF output.
Excellent. Thank you for that. Okay, so we'll go to some questions from the audience and go through those. So if anybody has any questions, type them into the chat. The first one, Sandy, how much time is allowed to triage a single case on average?
Yeah, so generously we've given 6 minutes. So I think our job plans are 90 minutes to triage a 4-hour clinic. Although that includes the admin time for processing the results as well, which would have been extra on top. So, and in real life, for me, it's about half of that. Although I'm quite used to it now. For some of my colleagues, it's probably between 3 and 6 minutes.
Fantastic. Thank you. Gabby, can I come to you? There's some great stats in this case study. How did you measure the success is the first part of the question. And then what are some of the lessons that you have learned from this project?
Yeah, that's a great question, John. So I think kind of there's two well, many elements to this, but two things to think about, and one of those is kind of what lenses we want to capture the impact of any kind of implementation. We always start off thinking about patient safety and accessibility. We think about clinical productivity and then any cash implications of any pathway that we work with. This obviously is a 2-week wait pathway, so there's some very specific KPIs that we looked at, like referral to treatment, for example, but then overlaying in that shifts to remote, other kind of efficiencies around how long it took to action these patients, some of the data that Sandy has just been talking about. So that's kind of absolutely fundamental. I think where we've laid on this since then is making sure that the qualitative evidence sits nicely alongside all of these key metrics. So making sure that we're placing patient experience at the center of feedback and iterating on the model to make sure we're really thinking about what the patient experience is of these journeys, and then making sure that clinical experience and usability of the system is placed at the kind of forefront of our code development and co-production. And Sandy is a very frequent guest panelist on any of our product sessions, so speaks very regularly to our product teams around how we could tweak the tech to make it more effective, more efficient in delivering on kind of our key outcomes.
Great, thank you. So we've had a question in the chat about rural and isolated communities. So Sandy, can I ask you, have you had any patient feedback from patients in rural communities, and how's it worked for them, and what have they said?
Yes, I should have included that. We've just done a kind of snapshot of between 100 and 200 patients we saw in a week and had feedback questionnaires. And we looked at some questionnaires beforehand as well of the issues people had. And as everybody knows, coming to the hospital and parking seems to be the biggest barrier to biggest upset with accessing healthcare, and people just hated that for us and having to come to Truro. And so Cornwall's a really long, thin county. It's very spread out. There's only one dermatology department. So yeah, the feedback's it was kind of 96% positive, and a lot of the individual comments were about being able to be seen locally, seen in the community, seen in community hospitals with free parking. And I think the other thing is that I was slightly trepidatious about the initial feedback, because there are the 30% of people who are being seen twice, that, they're being referred, they're being seen in the community clinic, and then they get a thing saying, yeah, we need to see you face to face. And then they come to see us face to face. And I thought that cohort would be, understandably a bit hacked off, that they'd had an unnecessary visit. But they haven't. Their feedback has also been positive. And I think the dynamic with the healthcare assistants is different, and they're being asked this big structured list of questions, and they're having some very detailed, one distance, one macro, one dermoscopic image of their lesions. And I think that was balanced out because they felt listened to, and that they'd had a really thorough assessment. And it also means in clinic you can be quite quick, because you don't really need to ask a history or even do much examining. You could pretty much say, thanks so much for coming to our imaging clinic. We're looking at a thing on your leg. Do you want to pop behind the curtain and we'll do that? Would you like a skin check? So yeah, so positive. And the rural thing and the travel thing, these are the majority elderly patients, aren't they, with non-melanoma skin cancer? That's gone well for us.
Great, thank you. Gabby, can we talk about the implementation? Could you just take us through how the implementation went? How did you ensure it was a smooth one? How did you support adoption of this?
Absolutely. So Sandy spoke about kind of these weekly meetings. I think first and foremost, it's not the most glamorous answer, but having some really rigorous governance when we kick off these projects, clear roles and responsibilities of who's going to be involved. Something Sandy alluded to is really how many different teams contributed to this. So we had the tech teams working really closely with our Isla tech teams, input from admin, from service managers on what the standard operating procedures should look like, all the way through to the date that we actually implemented. So really fundamentally setting up governance so that we have kind of organizational support for the project, making sure that when we get stuck, which inevitably happens, I think clinical safety is a good example of this. There's always a lot of anxiety and risk around any new process, regardless of whether that includes a software. So working really collaboratively with the team, having a regular weekly forum where we could bring any challenges that we were coming up against and work through that in a really methodical way. Super key to that is having all of the right people in the room. And I think for this project, we were very lucky to have quite a lot of access across the trust to anyone we needed to solve these challenges. And I would say, John, if we zoom out of that, kind of what's fundamental is making sure these projects align with organizational priorities and strategies so that when we do need to go for prioritization in a tech backlog or whatever it may be, we can make that case and articulate the impact that it's going to have across patient populations. So kind of to wrap that up, really getting that weekly governance in the diary, making sure everyone who needed to be was represented and bought into the project, and making sure that we could address any challenges that arose very, very quickly and efficiently.
Excellent. Thank you, Gabby. And Sandy, from your perspective in terms of implementation and adoption, how did it go?
I think it was fine. I try to remember it a year ago. There were the thing with Isla is that there were bumps and occasional glitches actually, because it was the software kind of we were developing it and using it really at the start. But it's all been very responsive. So we've communicated quickly, and issues or glitches have been fixed, within a day or two. And so that relationship's been key, I think, to the implementation. We had a couple of weeks where we ran dummy clinics with test patients and tested out admin processes and the image capture and all of that. Yeah, it's been organic. We grew it. We started with one clinic a week and then added clinics in different sites. So I think that's probably been key as well, that we ironed out the kinks when we had small numbers, and it's easy to go back and amend things. And now we've got big numbers, and it's working very smoothly. I still have, Gabby says that I'm involved in meetings, but what she means is I'm incredibly demanding, and I still have a long list of future demands, including DICOM expert and research databases. I just wanted to say one thing, which is that there are some questions about comparing with other software products and other systems, and that is that everything that's put into Isla is coded. So it's all drop downs. There's no free text the way we've designed it. And I can get Excel spreadsheets and CSV files at short notice, and some of it I can just do myself. Some of it needs a request for big numbers. So spreadsheets of coded data, which has been brilliant. And we've been able to present and publish a few things so far, and lots more. But that's a big difference to other. And it's the only hospital IT system I've ever used where you can get proper coded data out of it, and it's data that we've put in, so it's reliable. It's far more reliable than any of the hospital outcome data that I've ever encountered. In terms of ownership and data ownership, it's ours, it's the trust's, it's not Isla's. And I know there's been issues with other companies where they've had ownership, but it's not. I can get my data and images anytime I want in a few different formats.
Yeah, absolutely.
I'm not getting paid, by the way, by Isla. Never a penny, not a bean. So I don't have a conflict of interest or an axe to grind here, other than just wanting to progress efficient services, really.
Just to come in there and add to what Sandy said on the question of data ownership, we're the data processors, so we act on behalf of the trust, but no ownership of data changes hands in any way. So exactly as Sandy said, that kind of the trust retains that ownership of that data, and we act as a processor.
Super, thank you. Sandy, I've got an interesting question. Reducing the 2-week wait referral time, what strategies or features contributed the most to this improvement? Is there a feature or something that impacted you the most in your practice? What stood out and what stands out to your work?
So for me, it's hardline time and efficiency. So it's all about how long is a dermatologist having to spend with each case to manage them well. that's what's brought our wait times down, because we had, a finite number of clinics, clinic rooms, and clinicians, and and an increasing number of 2-week wait referrals, and if you have to see them all face to face, and your capacity mismatches your demand, then the wait times will grow. So, I was abroad actually in Australia for 6 months on a research sabbatical immediately before this, but our 2-week wait time had grown to weeks and weeks, like 12 weeks at its worst. And now it's down to, we're seeing people within a week or two. We're meeting all our targets. The targets have changed, haven't they? It's all about time to convey diagnosis and complete treatment, but we're meeting all those targets now. But it's down to that, and that's what I'd say if anyone's thinking about setting up a new system, is ignore what everyone tells you and just focus on making it as efficient as possible. And if it's not efficient, it's going to take extra time, and the doctors are doing admin and spending longer, and you're seeing fewer patients teletriage, then the whole thing's not going to be a success.
Excellent, thank you. And leading on from that, a question for you both. Sandy, could you take this first? If there's somebody on the call thinking about doing something similar to this and implementing a similar project, what would you say to them? Where should they start? What advice would you give them?
But in some ways, there's no need to reinvent the wheel. Get in touch. You can share our processes. You can share our training packages. Yep. We can, if you want to do it down the Isla route. And the only thing I'm not particularly involved in is costs. So that would be you'd need to get that. But I think get in touch, and it's been a very open, transparent process. I've seen all the costs and the IT security side of it and the data ownership, all of it's very transparent. So you just need to keep things transparent and honest, and apply common sense, basically, which is sadly lacking in a lot of IT-based initiatives.
And Gabby, how about from your perspective? What would you say?
I think from our side, probably planning is really key with this. Part of the reason why it's successful is we had a lot of flexibility with the integrations team. We could tweak things, we could update things. So being really open to kind of iterating as we work through the project, learning new things, reviewing data, changing tack slightly. I think that's kind of the really fundamental thing. So planning out what you want to do and being really open to being kind of responsive to new information and new data as you start that implementation process.
Great, thank you. Right, just go to some questions in the chat. Sandy, is there a time limit how many lessons can be checked during one? Not a time limit. Is there a limit on how many lessons can be checked in one appointment?
I was just typing an answer to that one. So we've specified 3, which was from my brain. I think that we put the system up before the BAD has some more concrete guidance on telederm services. I think their target's 2. I don't think it really matters, but certainly I wouldn't go beyond 3. And 3 is a bit of a pain when you're triaging. I have to get pen and paper out and write down 1 is left arm, 2 is this one in front of me. That's the only paper in the whole system is that. So yeah, 3 for us, or 2 would be reasonable. So it does depend on GPs mentioning each lesion that they're concerned about, and we've got a very clear protocol for the HCAs that if there's that basically the patient and the referral letter and the HCA's opinion all has to line up that it's definitely that lesion, because the real one big risk is that the GP is concerned about a lesion, and for whatever reason the lesion which is reviewed by the telederm doctor is something else, and nobody has made that connection. So yeah, the HCAs have got quite clear guidance about that. If there's any ambiguity or uncertainty, the procedure is abandoned and a face-to-face reviews arranged. If a patient says, I've got another 12 moles on my back that I want checking, I would like a skin check from a doctor, then the procedure is abandoned. And if the GP referral says on the back and the HCA has a look and there's 10 things on the back and they're not certain which it is, then it's flicks to face-to-face. So that safety side of it, we were quite hot on.
Thank you. The next question in the chat is, do you have any tips for making bookings straight to operating lists to make this work well and avoid wasting operating slots?
Yeah, so that's a movable feast, and it's to do with how comfortable you are with. So I presume this is about which patients are appropriate to list directly. So we've been employing more kind of Macmillan type cancer specialist nurses who can provide diagnosis appointments. So I'm comfortable putting um, obvious melanomas of the limbs and trunk straight to surgery because they all know that they're there for their mole to be checked and it might need to be removed. They get a standard pack of information about surgery, a kind of all the kind of things you'd go through in two-stage consent. They're given that in writing, and they get a standard letter which says if you'd rather discuss things with us or meet one of us face to face, if you'd prefer that, then coming straight to a list, please get in touch and we'll arrange that. So there's a lot of work there to make it acceptable and safe for patients. So the things that we see are anything that's going to involve a graft or a flap on the face, because I think that needs a proper consent discussion. Anything which is a BCC at a high-risk site, which would be suitable for radiotherapy as an alternative. We've got a really good superficial X-ray service, which has outcome results as good as surgery. So BCCs on the nose in old people, for instance, then we'd see that. But anything needing a biopsy, we're quite happy to list, and anything needing a straightforward excision, particularly limbs and trunk, we'll list. And then the rest, facial lesions, which are linear closure, is a bit of a judgment thing. And I think I quite often look at their past history. If someone's had 4 or 5 things excised from their head and neck and they've got another one and they kind of know what's coming, I might direct list them with the caveat that they can get in touch. But I think the important thing is to leave open a route whereby the patient can change that plan and doesn't feel corralled into turning up on the day for something that they feel uncomfortable about.
Excellent, thank you. There are a couple of questions about costs and fees in the chat, which I think we should answer outside of this webinar, so we can pick them up outside of this call. The next question I have is a data security and patient confidentiality one. Could you answer this one, Gabby, please? So with remote access and collaboration across teams, how does the Isla platform support data security?
Yeah, absolutely. So I think kind of the key thing for us to think about is there's a real big focus and a real big push on remote care that we've really focused on over probably the past 5 years, a little bit longer. And this is fundamentally not to say that patient-submitted data hasn't always been useful. So I think most of the clinical teams that we work with, not just in dermatology, across kind of 45 different pathways, understand and highlight the importance of patient-submitted data. But the big barrier to accessing that data has been having a really secure way to capture, receive, and store that information so it can be referenced as part of a clinical decision. In this pathway specifically, what's interesting is having clinicians at different sites, but wanting to be able to have the same access to the same information and do that immediately. So fundamentally, we focused on making sure that as an image or any piece of data is captured within Isla, it's immediately accessible to the different teams that need access to that data, but of course done so in an encrypted and secure way. So it's a cloud-based platform. The upload process is encrypted, and we have this really rigorous kind of storage where nothing's stored locally on any device. So these iPads that are being used, for example, smartphones, when they're being used, aren't storing any local information. That information is uploaded straight into the platform and reviewed, obviously through an access-controlled portal.
Excellent, thank you for that. Sandy, can we talk about AI and the potential of using 3,000 images as a database? Could you take us through either what you've done or what you plan to do in the future and any research around that?
Yeah, so I mean, there's lots of opportunity and some risk around AI in dermatology. In skin cancer diagnosis. Most AI diagnostic algorithms at the moment are based on just on looking at the dermoscopic image, which is nice for patient confidentiality because they're absolutely non-identifiable in themselves. So from the start, we have asked patients to sign and actually sign with their finger on an iPad. 2 separate consents. One is, are you happy for these images to be uploaded to your medical record, which is a standard kind of imaging consent. It's not exact wording, but and then another one is a separate consent for, would you be happy for your anonymized images to be used for teaching and training, including the training of artificial intelligence diagnostic algorithms. So, and that's coded as well. So we can filter out patients who've said, obviously everyone says yes to the upload to the medical record or we wouldn't proceed with it, but we can filter out patients who didn't want the teaching and training one. And so we're running a study at the moment on that. And the kind of LREC ethics committee were happy with that kind of blanket consent because it's anonymized images. So the image, I must stress, the images that we're capturing in clinic with these dermatoscopes and iPads are vastly superior to any images I've ever been sent from primary care or other sources. We're very, very fussy. The difference between a super sharp in focus dermoscopic image and one which is just slightly blurry because it's a little out of the focal range, or there's been movement, or there's bubbles, that difference is the difference between being able to confidently make a diagnosis and needing to see the patient. I can't remember where I was going with that. But yeah, so where I was going with that is that we're building up a really big, I mean, we've got between 10 and 20,000 dermoscopic images of lesions, and we're going back and retrospectively adding their diagnostic tags. And my vision, along with others in the BAD and across the country, is that we end up contributing to a anonymized nationwide research database that we can test and train AI products on real world data, so that consecutive referrals, no exclusions, no kind of, we don't do dysplastic nevi, as in some recent papers, but you know, that real world consecutive series, because there's a stack of data and evidence about AI in artificial research settings, and that's how the products have all got licenses, but there's very little on real world consecutive reliable data.
Fantastic, thank you. There's a question, Gabby, around when a patient doesn't have access to a network or doesn't have internet connection, could you just take us through how that works, please?
Absolutely. So it's actually quite a timely question. This week we have released offline access, which is incredibly exciting, not just for dermatology implementations. A lot of our community nursing teams work in rural parts of the country and going to patients' home where there's no access to Wi-Fi or internet or whatever it may be. And that allows us to kind of store the image until connection is reinstated and then uploaded onto the platform. From a patient submission perspective, fundamentally, we don't request that patients download anything or install any kind of software. It's not required of the flow, and the intention there is to make the burden on the patient as kind of minimal as possible. This offline access will also allow us to ensure that if any dropped connection, kind of once that patient's back in a kind of appropriate zone, is uploaded onto the platform. But yeah, we're very excited about that and very proud of it.
Fantastic, thank you. Right, there's a question coming just to ask if I guess some of your case studies are would recommend in a professional capacity. I'll probably think yes.
Yes,
so
I can.
Yeah, go for it, Kelly.
Yeah, absolutely. So I think something that we've been very fortunate about and has really been a testament to our collaborations is that we have lots of wonderful partners who are very happy to chat through with anyone who's trying to implement a similar thing, whether it's with ILO or just to learn kind of how those implementations went and what the key findings were. So I think Sandy's already offered himself up on this call, but a lot of our other partners across to that question in the chat, the website would also be happy to be introduced and have those conversations.
Fantastic, thank you. Well, I think we have covered all the questions in the chat. We've still got a couple of minutes, so if anybody's got any questions, type them in. But I'd like to ask one more question to you both in terms of a key takeaway. If there's one key takeaway you'd like people to go away with from this discussion, or one piece of insight that you'd like them to take away, what would that be? Gabby, can I start with you for that one, please?
Yeah, absolutely. I think as an implementation team, something we've learned working in teledermatology is that there isn't one solution that fits every single patient population and every single trust that we work with. We have a number of different telederm implementations that leverage slightly different models, Santi's click model, medical photography, things like that. So really starting the conversation of how this might look in your organization, sitting together and really mapping out and getting to the core of what problem you're trying to solve is really the thing that kicks this off. And it might be that you learn that it's not quite right or you want to approach it in a slightly different way. But I think that conversation is the thing that everyone should really start with, and that drives forward really meaningful understanding of what this will take at an organizational level and at a project level.
Fantastic. Thank you, Gabby. And Sandy, over to you for one takeaway, please.
I've got two. One is
Fine.
don't be afraid to be clinician led. So, I don't know anything about computers and IT and software platforms and HL7 connections, but nonetheless, I think this pathway it will be successful if it's driven by clinicians. And the other one is walk away from people you don't trust. I dealt with quite a few different software agencies, and you get a vibe for the culture and the communication style and how adaptable and how it's going to fit with you. I think if that doesn't feel like it's going to work, it probably won't work.
Fantastic. Thank you. Seems we've got a couple of minutes. I've got one more question. Sandy, what have patients said in terms of their feedback? What have you heard from them in terms of using this technology?
We did some prior to our the AI thing. We did some patient questionnaires. This is slightly on a tangent, but we did some in-depth focus group. That's the word. Sessions about how would they feel about AI, how do they feel about AI in general, how did they feel about us sending their images to an AI company even in another country, how did they feel about their images being part of training data sets, and the response was overwhelmingly positive, and it was kind of, most of it was it's everywhere. All the best technologies are available to companies like Google and Microsoft and the others, and why not? And why shouldn't the NHS have it? So rather than my fear, which is that people are like, oh, I don't want to get involved in that, it was more like that, the NHS shouldn't be deprived of up to the minute technology, so we should go with it. And people are really mellow about smartphones and pictures and cloud-based and images. It's part of normal life now. We're behind in the healthcare profession, really, not ahead.
Fantastic.
Just to add to that, John, one of the things we've prioritized is really clear signposting to patients about how their data is used and what options they have available to them. And when you are very candid with patients and really clear on kind of what information is available to them, I think that really builds kind of the longevity and the trust with these cohorts so that they feel comfortable to engage with the interventions that we're talking through.
Fantastic. Thank you both. And I think that's all our questions in the chat. And I think that's every question from me as well. So I'll look to close the session here. So like I mentioned at the start, the session has been recorded and there'll be a write-up from the HTN team. So you can read or watch it back and share it with your colleagues. It's worth checking out the case study as well, because there's a document on that. So you can read about that in detail or share that with your colleagues too. And finally, I'd just like to say thank you to Sandy and Gabby for joining us today and taking us in depth into this project, because I think it's a fantastic project that's made a massive impact and has won an award in the HTN Awards. So peers have noticed its impact as well, which is fantastic and something you should be really proud of. So that's it for this webinar. Thanks to everybody for attending as well. And I'll look to close the session here. So thanks again, everybody, and have a nice day.
Thanks, John. Thanks, Andy.
Cheers. Thanks. Bye.